Hello and welcome to Chapter 7 in Electronic Health Records. We're going to be discussing clinical documentation and reporting. So if you want to follow along in the textbook, we're going to start on page 182 right underneath the learning objectives. So in 2008, only 41% of hospitals had a basic EHR system. By 2015, more than 80% of hospitals met meaningful use requirements for an EHR. So that's a very big jump from having basic EHRs in 2008 to having basically full EHR systems in 2015 where they were actually meeting the meaningful use requirements. The implementation of the EHR has streamlined data entry and encouraged interoperability of data and information. Depending on compatibility of the clinical system interface with other systems such as radiology, laboratory, pharmacy, and transcription services, healthcare staff members enter patient and clinical data either automatically or manually to create the EHR. Examples of clinical data include the history and physical examination, or H&P, progress notes by all clinicians, immunization information, lab results, and medications. So let's go on through our PowerPoint, get through these learning objectives over to our first slide, and we're still on page 182. So clinical documentation, which is also known as clinical outputs, contains data related to the patient's clinical status that is entered into the patient's EHR or paper health record. Data entered into an EHR can be classified as either structured or unstructured. If you'll remember, we learned all about that in health records. Structured is there's going to be a specific, organized fashion that this information is stored within a database. Items could include date of birth, sex, race, lab results, your ICD codes. Unstructured data is information that is stored in the free-form format, meaning there's just a text box that you're going to type information in. Like if you were going to freehand a progress note in a paper record, there's no format for you to specifically follow. So remember, unstructured is going to be your free format text. Those examples again are your progress notes, test interpretations, and operative reports. Data collection in an EHR occurs through a combination of manual and automated methods. Manual data collection of demographic and insurance information is often initiated by a staff member upon initial patient contact with the healthcare facility. The data is typically obtained from a pre-printed form that the patient has completed or during an in-person interview. However, at times, the information is still collected over the telephone, and the staff member subsequently enters the information themselves into the EHR system. In automated data collection, this occurs when data from the initial patient encounter is automatically copied over to each new patient encounter using an automated data capture. Automated data collection is the preferred method of data capture because it requires less personnel time, avoids repetitive requests for information from patients. How many times have you went to the doctor's office and they continually ask you the same questions over and over and over? This kind of eliminates that. If I go to a clinic for the very first time and I fill out that patient information sheet where I give them my address, my insurance information, all of my normal demographic information, and the next time I go back to that same doctor's office, I don't have to fill that form out again. They still have the same information. They may verify that something hasn't changed, like my address or my phone number, but they're not collecting the same pieces of information over and over and over because they can just automatically transfer that over to that next encounter. And it also, the third thing it lists here on page 183 is that it may allow for more consistent data capture. So that's another benefit there. All right, moving on to our some clinical documentation. So let's talk about our history and physical here for a minute. So the history and physical is a part of most patient encounters with healthcare providers and is a valuable tool for the healthcare provider in the identification of diagnosis. It consists of two main elements, a subjective element and an objective element. So we remember also from health records that subjective is your personal opinions and statements, whereas the objective is based on clinical facts. So our review of systems was information that we obtained from the patient, which again is their personal opinions and their statements. So a review of systems was subjective, but the physical exam is when the physician actually looks over the patient, puts hands on the patient. They are basing that information on clinical facts. So your physical exam is objective. All right, moving on to page 184. So the history is the subjective element of the H&P because it is obtained from the patient or a family member, as well as a review of previous medical records. Subjective element is based on personal reporting and opinions. The history begins with the chief complaint, which is the patient's stated reason for seeking health services. The chief complaint is then followed by one or more of the following components: history of present illness, past medical issues, allergies, medications currently prescribed to the patient, and family and social histories. Then we have our physical exam, and again, we talked about that just a second ago, that's our objective element. It's based on facts and not subject to the interpretation required for subjective information. The procedure is conducted by the nursing or medical staff and consists of an investigation of the patient's body systems, an assessment of his or her condition, and a treatment plan. The inventory of each body system is called the review of systems. The review of systems consists of the following system assessments. Now, let me kind of go back into when I said before that a review of systems can be subjective. From my background personally, if you look at a history and physical from North Mississippi Medical Center, it's going to contain two separate sections. One that they call review of systems. That is information given to the physician by the patient. Then you have the physical exam. They both go through the same body systems, but one is from the view of the patient and one is from the view of the physician. So again, in North Mississippi Medical Center world, review of systems is subjective, physical exam is objective. So let's go through these different system assessments. First of all, we have general. This could include the appearance of the patient, such as a 66-year-old Caucasian woman in no acute distress. Patient is alert and able to discuss medical history. Then you have your vital signs. It's going to include blood pressure, pulse, respiratory rate, pulse oximetry, and body temperature. Then you have your head, ears, eyes, nose, and throat, or HEENT, respiratory, cardiovascular, abdominal, gastrointestinal, genitourinary, musculoskeletal, and neurologic. Now, sometimes physicians will break some of these out so you may have more points. Sometimes you'll hear or see a physician dictating a report, an 8-point review of systems or a 10-point review of systems or a 14-point review of systems. And so some of these guys kind of break these systems down into, more specific categories based on what their specialty is. So everyone could be different. But depending on the patient's reason for visit, the physician may conduct a complete review of systems or a selective review of systems that focuses on the body systems involved with the patient's chief complaints. For example, a high school student whose chief complaint is that he or she wishes to participate in sports will likely need a complete review of systems to ensure his or her health status is appropriate for participation in the sport. However, a 10-year-old whose chief complaint is throat pain will likely receive only a general exam, along with a check of vital signs and a review of the HEENT system. Once the healthcare provider has reviewed the history of the patient, physically examined the patient, and evaluated all recent lab and diagnostic test results, the provider assesses the patient's diagnoses and decides on a treatment plan to alleviate the patient's condition. Depending on the preference of the healthcare provider, the provider may type the H&P directly into the EHR or dictate a report and have a transcriptionist type and upload the report into the patient's EHR. And uploading is the process of transmitting that file from one computer to another computer or portal. All right, moving on to our different templates here. Many of the clinical inputs to an EHR system are accomplished using a template, which is a pre-formatted file that provides prompts to obtain specific, consistent information. Now, let's take this out of context here. All right, let's not talk about a template in the healthcare environment. Let's talk about a template in a way that you may have used one, or a way that you may use one in the upcoming future as a sophomore. Think about Microsoft Word templates. There are templates in there for your resume. And so depending on what template you use, it'll change the format, but no matter how many times you pick that one document and open it, it's going to continue to ask you for the same specific information, and it's going to be consistent with how it asks for that information. So if you have 3 past jobs and you want to put those jobs on your resume, the format's going to be the same. The dates and times of employment are going to be in the same spot. They're going to try to prompt you to enter the information so that it's a 2-digit month, a 2-digit day, a 4-digit year. So you kind of see where I'm going with this template. It's just actually, prompting you to be specific and consistent in your information. So these templates work the same way in the healthcare industry. Now, for healthcare providers, the use of templates do the following. They indicate required fields that must be completed during the documentation process. It ensures consistent data gathering techniques among users, allows for efficient data entry through the use of structured input options such as drop-down menus and checkboxes. It provides immediate data population of the EHR system. It avoids the added expense of hiring a transcriptionist to document patient information. It facilitates easy access to data because of its consistent format, thus avoiding time-consuming searches. And it enables faster and more precise reporting and analysis of data because of its format and consistent elements. So clearly, EHR templates offer several advantages. However, their use should never hinder thorough documentation by a healthcare provider. For any selections not available in drop-down menus, a provider will need to input patient information to ensure accuracy and completeness of the patient record. All right, moving over to 186. Certain patient diagnoses or conditions may dictate the creation of a specialized template that offers information fields tailored to specific documentation needs. Specialized healthcare providers may also need specialized templates. For example, a detailed eye examination template like the one shown in Figure 7.1 on page 186 would be a useful tool for an ophthalmologist. And depending on the policies of a healthcare organization, staff members may conduct special assessments to determine these special needs. So if a cardiologist is going to see a patient, they're going to gather different information than a nephrologist or a urologist or a pediatrician. They're not all looking for the same information. So each one of these specialists might require their own specialized progress note or their own history and physicals to be more specialized for those specific body systems that they are specialized in. All right, let's move on to our next slide, talking about nursing documentation on the bottom of 186. In the inpatient environment, such as an acute care hospital, rehab hospital, or psychiatric hospital, nurses spend a considerable amount of their shifts documenting the care and treatment of the patients under their care. There are many patient assessments that nurses conduct and document upon admission and throughout a patient's stay. Nurses conduct an admission assessment shortly after the patient's arrival to the hospital room. This admission assessment is similar to the history and physical exam that was previously discussed, but it's completing from the nurse's perspective. Major assessment areas on the nursing admission assessment typically include general admission data, patient history, physical assessments of all major body systems, and spiritual, cultural, and social histories and perspectives. And you can see on page 187, Table 7.1 has some nursing admission assessment information. We have those different major assessment areas broken down on the sides, and then some of the data elements that might actually be included in each one of those areas. All right, moving on to our progress notes here. The bottom of 187. Progress note to the portion of the health record in which healthcare providers of all disciplines document the patient's progress or lack thereof in relation to the established goals of the care plan. Healthcare providers may choose to write or transcribe progress notes in any format. For healthcare organizations that have adopted the EHR system, this task can easily be completed through the use of customized templates. These templates provide information fields that cater to certain disciplines and specialties. For example, a template for a physical therapy progress note may include checkboxes to indicate whether the patient can bear weight on the right side and on the left side, and drop-down menus with options for indicating the patient's range of motion and pain level. A progress note template for a cardiologist may allow healthcare providers to seek different causes of syncope. Use of a progress note template lessens data entry time and ensures the inclusion of all pertinent data elements. All right, let's talk about cloned progress notes. Don't like these. These are kind of a no-no. So one area of concern related to EHR progress notes has been the increased use of cloned progress notes. A cloned progress note is a note that has been partially or totally copied from an existing progress note. The copied note is then updated by the healthcare provider to include any new information. So clone progress note is kind of the same thing almost as copy and paste. You're taking information from a previous note and you are putting it in a new note for a new day. This shortcut may save time, but it can also result in inaccurate or outdated documentation regarding a patient's health status and progress if the healthcare provider forgets to make the necessary updates to the existing note. Consequently, other healthcare providers may make inappropriate medical decisions based on incorrect information, which could have dire consequences for the patient. Clone progress notes may also affect the process of coding diagnoses and procedures for reimbursement purposes. Clone progress notes that do not accurately reflect patient diagnoses and treatment may result in inaccurate code assignment, which in turn could lead to reduced reimbursement and increased focus and monitoring from payer sources. The Office of Inspector General, moving on to the next slide here, in the U.S. Department of Health and Human Services, is responsible for combating healthcare fraud, waste, and abuse, and for working to improve healthcare efficiency. To that end, the OIG routinely audits the billing and coding practices of healthcare organizations. Health record documentation that support code assignment and bills submitted for Medicare and Medicaid reimbursement. The OIG establishes an annual work plan of areas of health documentation and billing practices to be addressed and audited during the year. The goals of the OIG are to ensure that healthcare organizations maintain accurate coding and billing records and that documentation is accurate and consistent throughout the health records. Because of initial problems with clone documentation in the early years of the EHR implementation, the OIG included clone documentation as a focus area in 2012, 13, and 14 work plans. The use of clone documentation was sufficiently reduced so that the OIG removed the work plans after 2014. Alright, so let's get into e-prescribing at the bottom of 189. Another documentation feature available to users of EHR systems is electronic prescribing, commonly known as e-prescribing. This feature allows a physician, nurse practitioner, or physician assistant to electronically transmit a new prescription or renewal authorization to a pharmacy. The healthcare provider enters the medication order along with the location of the patient's pharmacy into the patient's EHR, and the e-prescription is automatically transferred to the pharmacy where it's filled for patient pickup. All EHR systems must have the e-prescribing feature because meaningful use requires that more than 50% of all permissible prescriptions written by an eligible healthcare provider are electronically transcribed using certified EHR technology. For healthcare providers, the benefits of e-prescribing include improved prescribing accuracy and efficiency, a decreased potential for medication errors and prescription forgeries, and more accurate and timely billing. Using e-prescriptions lessens the risk for potential medication errors due to unclear handwriting, illegible faxes, or misinterpreted prescription abbreviations. EHR systems also have the ability to alert a healthcare provider if he or she prescribes a drug to which the patient is allergic, resulting in improved medication safety. Many studies indicate that the use of e-prescribing feature in EHR systems has reduced medication errors from 12 to 15%, which translates to 17.4 million medication errors averted per year. E-prescriptions also benefit patients in terms of improved accuracy in medication administration, more effective and efficient communications between patients and prescribers, and timely notifications for refills. Overall, e-prescription functionality improves patient care quality and reduces healthcare cost. And you'll see on our slide, just as in the book, we have an example of an e-prescription here. All right, moving over to 191. Although e-prescribing affords many benefits to both patients and healthcare providers, there are also some challenges associated with the use of this technology. When EHRs were first implemented, the major challenge of fully implementing e-prescribing involved the dispensing of controlled substances. A controlled substance is a drug declared by the U.S. federal or state law to be illegal for sale or use by the general public, but legal if dispensed per a healthcare provider's prescription. The basis for determining whether a drug is a controlled substance is the drug's potential for addiction, abuse, or harm. Although U.S. federal and state laws governing the distribution of controlled substances were placed prior to 1970, in that year the drug counterculture of the 1960s led the U.S. government to enact stronger legislation regarding the manufacture and distribution of narcotics, stimulants, depressants, hallucinogens, anabolic steroids, and chemicals used in the illicit production of controlled substances. This legislation, known as the Controlled Substances Act of 1970, placed tight controls on the pharmaceutical and healthcare industries and outlined 5 schedules of controlled substances based on potential for harm. This legislation established additional procedures for healthcare providers writing prescriptions for controlled substances. These procedures required that prescribers use hard copy or printed prescriptions when ordering Schedule II controlled substances. Consequently, the use of e-prescriptions for these substances had to be approved by individual U.S. state boards of pharmacy before this technology could be implemented. In August 2015, Vermont became the final state to permit e-prescribing for all medications, including all controlled substances. So prior to August of 2015, Vermont was the last state in the U.S. That would actually allow e-prescriptions for those controlled substances. Otherwise, you had to have a written prescription or a printed off prescription to actually get those filled. Even though the legal barrier regarding controlled substances has been eliminated, using e-prescribing to order controlled substances is still a challenge because many EHR systems have not upgraded software to handle the e-prescribing of controlled substances. In addition, many providers are uncomfortable using e-prescribing for many of the frequently abused painkillers such as oxycodone, hydrocodone, and morphine. Fearing breaches in the security of the EHR may allow for fraudulent prescriptions. Another challenge associated with e-prescribing is the lack of interoperability between healthcare facility EHR software and some pharmacy software. An e-prescription is not useful to a patient if he or she is unable to fill it at the pharmacy. If a pharmacy software does not communicate with the healthcare facility's EHR, a traditional handwritten prescription must be used. All right, moving over to 192, talking about clinical results reporting. So clinical reporting, also known as clinical outputs, contains data that can be extracted from a patient record and compiled in a meaningful way. For example, a physician might run a cumulative report of the lab results of a patient to easily determine if trends in a lab value need to be addressed. The transcribed reports of an H&P, as well as consultations and radiology reports, are additional examples of clinical outputs. All clinicians involved in the patient's care can then use this data. Data mining is the process of searching for and examining data to organize it into useful patterns and trends. Data mining and reporting of structured data can be accomplished quickly and easily using an EHR system because the fixed nature of structured data makes it easy to search for, query, and quantify. Data mining of unstructured data is a more of a challenging process that requires researchers and developers working hard to simplify. A wealth of information is buried in the narrative provider notes of an EHR, waiting to be manipulated and studied. So again, your unstructured information, again, that's that free typed information. It could be a sentence, it could be 2 words, it could be 4 paragraphs. So you can't easily search information in those settings because you don't really know what to look for. If you have a drop-down box that only has 3 options, then you can easily search for that information because, again, you only have 3 options. You know it's going to be entered that way every time because it's not a free typed response. It was selected from a drop-down list. Clinical results reporting is an EHR system function that allows healthcare providers to view laboratory and diagnostic test results immediately, provided there is an interface between the clinical results system and the EHR. This feature satisfies one of the National Patient Safety Goals of the Joint Commission. Hospitals accredited by the Joint Commission are required to comply with the National Patient Safety Goals, which were established to help hospitals address specific areas of concern in regard to patient safety. The first set of National Patient Safety Goals became effective on January 1, 2003, and the goals are annually updated by the Joint Commission based on the recommendations of the Patient Safety Advisory Group. This is a panel of widely recognized patient safety experts that includes nurses, physicians, pharmacists, risk managers, clinical engineers, and other professionals with hands-on experience in addressing patient safety issues. Hospitals must have policies and procedures in place that specify the time frame during which healthcare providers must be advised of test results that are considered critical. Each healthcare organization is responsible for specifying the values and circumstances that define a critical test result. These specifications should be defined in a facility policy and medical staff bylaws. For example, the hematocrit laboratory value might be considered critical if it was below 18% or greater than 55% for an adult. A chest x-ray with suspicious shadow may also be considered critical. All right, moving down into our automated clinical results reporting. The clinical results reporting feature of an EHR system addresses a long-standing problem associated with phone and fax communications of test results, which is the inability for healthcare providers to receive those communications during times they're not in their offices. So if it's on a weekend or it's a holiday or it's during the nighttime hours when they're not there, they're not going to get the communication. When EHR systems are able to interface with laboratory computers and other computers that output test results, healthcare providers can use personal computers or mobile devices to access test results and order medications, treatments, and further tests to address the reported results. This is an example of the automatic method of results entry. In addition, many EHR systems are able to generate email or text alerts to notify providers of critical test results or other important information. In an environment that does not have an EHR system interface with lab computers, the lab sends a printed report via fax to the prescriber's office, and then a staff member scans the report into the EHR. This is an example of the manual method of results entry. However, the preferred method of retrieving lab and test reports would be via automatic transmission or an interface between the lab system and the EHR. All right, moving over to the meaningful use and public health objectives on page 194. As you've learned throughout this text, there are core measures of meaningful use that must be achieved by healthcare organizations if they plan to receive incentive payments for EHR adoption. Stage 1 and Stage 2 requirements of meaningful use have been implemented or are in the process of being implemented by healthcare organizations. EHR systems are able to demonstrate compliance with the requirements by collecting data and running reports that indicate core measure compliance. They also reveal non-compliance in core measures. Stage 1 of meaningful use has 3 public health objectives that require the capability of an EHR system to submit electronic data to public health agencies for: the first one, immunization registries; the second, reportable laboratory results; and third, syndromic surveillance. The U.S. government included these meaningful use requirements for EHRs to improve collaboration between clinical and public health organizations at both local and state levels. So let's break each one of these down. Let's first talk about our immunization registries. Healthcare clinics can report confidential, anonymous vaccination data about their patients to public health agencies. Immunization registries are important tools to help remind patients when vaccines are past due and consolidate immunization records for patients who may have multiple healthcare providers. Second, lab results. There are certain lab results that are required to be reported. Reportable laboratory results for meaningful use is the electronic transfer of data from laboratories to PHAs. Reporting on conditions of concern to public health is a cornerstone of public health surveillance and includes the reporting of laboratory results that may indicate a notifiable condition. The Council of State and Territorial Epidemiologists determines the list of reportable conditions that are nationally notifiable on a voluntary basis to the CDC by each state PHA. Some examples of conditions that are reportable include anthrax, measles, rubella, polio, smallpox, and botulism. EHR systems are beneficial in this type of data reporting because they can support the timely reporting, data entry error reduction, and a more complete data reporting. And our third, syndromic surveillance. Syndromic surveillance is the process of using near real-time health and health-related data to make information available to the health of a community. This information includes statistics on disease trends and community health behaviors. Syndromic surveillance is particularly useful to local, state, and federal PHAs for the awareness of public health trends, determining when emergency response is needed, and identifying an outbreak or a potential outbreak of disease. Patient encounter data from healthcare settings are a critical input for syndromic surveillance, which is greatly enhanced with the transfer of patient data via EHRs. Clinical data are provided by hospitals and urgent care centers to PHAs for all patient encounters. The PHAs then use the Public Health Information Network, which is the national system for the electronic exchange of data operated by the CDC, to electronically exchange data and information across organizations and jurisdictions. Alright, so that finishes up Chapter 7. Our chapter summary is relatively brief, so I am going to read through it on page 196. Clinical documentation and reporting are at the core of the EHR system, making this system an interactive repository of timely, valuable, and possibly life-saving data. Data collection for the EHR occurs through a combination of manual and automated methods. Automated data collection is the preferred method of data capture because it requires less personnel time, avoids repetitive requests of information from patients, and allows for more consistent data. Patient demographic data is usually entered manually at the patient's first encounter with the healthcare organization and is automated at subsequent visits. History and physical examination results Progress notes, assessments, consultations, and operative reports are examples of documents that may be manually or electronically added to the EHR. An area of concern related to EHR progress notes has been the increased use of cloned progress notes. Healthcare providers must ensure that their documentation is accurate at all times. Diagnostic tests, such as lab results, are ideally transferred directly from the laboratory computer to the EHR. E-prescribing has greatly benefited patients and providers with improved accuracy in medication administration and efficiencies related to communication and refills. Without the capability for exchange of clinical data inputs and outputs, the EHR system would merely function as a static electronic file folder. From filling e-prescriptions to the emergency review of lab results, the electronic exchange of clinical information has proven to be invaluable to patients and their caregivers. Healthcare organizations must achieve core measures of meaningful use if they plan to receive incentive payments for EHR adoption. Stage 1 requires EHRs to have the ability to submit electronic data to public agencies for immunization registries, reportable laboratory results, and syndromic surveillance. So be sure to read through this entire chapter. You're going to want to review your acronyms and initialisms. Just be familiar with those. And good luck and happy study.